brachial plexus, how the roots, trunks, divisions, cord are formed, relation of the brachial plexus, connection to the clavicular, supra, retro and infraclavicular parts, branches arising from the different cords, able to draw the brachial plexus, cutaneous supply of the arm, and applied anatomy. You know very well that when the nerve is emerging from the spinal cord, they have got the two basic roots. One is the arising from the posterior side, we have known as the posterior rami, another is arising from the anterior side, we have known as the anterior rami. In other words, we can say the dorsal and ventral rami. Now the brachial plexus, actually the plexus is known as a bunch of the nerves which make at a different site. Now over here we can say, as name indicate, brachial plexus. It means a plexus of the nerve which form at the cervico-pectoral region. This is the cervical regions, this is the pectoral regions. We can say cervico-pectoral region and supply the brachium portion. Arm is also known as the brachium, forearm is also known as the antebrachium, and the nerves which are emerging from this plexus which supply whole of the upper limb. In other words, we can say, because over here the upper limb is started, that's the brachium portion, and the antebrachium portions and the hand portion. Now the brachial plexus is formed by the ventral rami of the C5, C6, C6, C7, C8 and the T1, which give rise nerve that supply whole of the upper limb. Now how they are formed? First of all, these are the roots. The roots which is arising from the ventral rami, that is the C5, C6, C7, C8 and the T1. After that, the roots when combined together, they forming the trunk. There are three trunk, upper, middle and the lower trunk. From the each trunk there are two divisions are emerging. One is the anterior, another is the posterior divisions. In such a way, according or in relations with the trunk, there are three trunk. Obviously there will be the three anterior divisions and three posterior divisions. From the divisions, that the cords are formed by the union of these divisions, and the cord are arranged as a medial, lateral and the posterior cord. Then if you see that the formations of the trunk and divisions, first of all, when we just observe this pig, that the roots is arising from the C5 and C6, which is forming the superior or the upper trunk. The C7, which is forming the middle trunk. The C8 and T1 is forming the inferior trunk. Then each trunk, from the each trunk there are two divisions is arising. One is the anterior, another is the posterior. One is the anterior, another is the posterior. You can see over here the anterior and the posterior divisions. Now how the cords are formed? From the anterior division of the superior trunk and anterior division of the middle trunk. You can see over here the anterior division of the superior one, the anterior divisions of the middle one. When they unite together, they forming a cord. That cord is known as the lateral cord. This one, that is the lateral cord. Now as the posterior cord, how it is formed? All the components of the posterior division of the trunk, as well as the superior, from the superior trunk, the posterior division of the superior trunk, the posterior division of the middle trunk, the posterior division of the inferior trunk. When all these three posterior division of the three trunks unite together, they forming the posterior cord. Then the inferior trunk, which is giving the anterior division, directly forming the medial cord. Now, what is the relation of the brachial plexus? Brachial plexus lie at the posterior triangle of the neck over here between the angle formed by the clavicle and the sternocleidomastoid muscle. This is the clavicle muscle and this is the sternocleidomastoid. This is the triangle which is forming over here, and the nerves which is just emerging between the scalenus anterior and scalenus medius muscle. Over here it is covered with the skin and the deep fascia and the platysma muscles. It is also closed by the suprascapular nerve, external jugular vein, inferior belly of the omohyoid muscles. You can see over here that is the middle scalenus muscle and that is the anterior scalenus muscle. In between, the brachial plexus nerve is emerging. Over here you can see easily that is the middle scalenus muscle is showing over here, and that is the posterior one. Posterior is just behind or deep to these nerves. You can see over here that is the nerves is emerging from the anterior as well as the medial scalenus nerve, and this is the relations of the subclavian artery and this is the anterior scalenus muscles over here, and that's the middle portions of the anterior scalenus muscles. You can see easily over here. Now the posterior card, relations of the brachial plexus in the axilla. What is the relation in the axilla of the brachial plexus? Relationship of the brachial plexus into the axillary artery. You know very well the axillary artery has got the three parts. The first part, second part and third part. And these three parts are made by the presence of the pectoralis muscle, pectoralis minus muscle. Posterior card, posterior lateral to the first part of the axillary artery. This is the posterior card. This is the first part of the axillary artery. Now you can see that the posterior lateral of the first part of the axillary artery. Now the lateral card, this is the lateral card. Lateral card, lateral to the second part of the axillary artery. This is the axillary artery. This will be the lateral part of this axillary artery. Lateral to the second part of the axillary artery, that is the lateral cord is present. Then the medial cord. You can see over here. Medial cord is just present on the posterior side, but it is on the medial portion. We can say posterior-medial to the second part over here. That is the second part of the axillary artery. Below the pectoralis minor muscle, this is the pectoralis minor muscle, which gives just below to that the terminal branches of the nerve is just emerging from there. Now this is the another view which is showing the branches of the brachial plexus. As again when we go from the roots we can see that the C5 and C6 which give C5 dorsal scapular nerve is directly emerging from the root. One is that. Another from the C5, C6 and from the C7 you can see the long thoracic nerve is emerging over here. When the superior trunk is forming over here by the union of the C5 and C6, the nerve which is emerging from the superior trunk over here, which directly reach to the subclavius muscle, which is just below to the clavicle and subclavius groove. If you have remember, that is the nerve to the subclavius. Then from the anterior divisions over here, when we see that at the junction of the trunk and the anterior division which is emerging from the superior trunk, another nerve which go toward the suprascapular side or supply the supraspinatus muscles or other structure, that is the suprascapular nerve over here. Now from the cord, that the two or three nerves is emerging over here. From the lateral cord, the nerves is emerging, a big nerve, that is the lateral pectoral nerve is emerging from the lateral cord. From the posterior cord you can see over here that is the upper and the lower subscapular nerve is emerging. That is the upper subscapular nerve, that is the lower subscapular nerve, and the thoracodorsal nerve is also emerging from the posterior cord, you can see over here. And from the medial cord, medial pectoral nerve and the medial brachial cutaneous nerve is emerging. At the junction of the, or at the terminal point, you can say, of the medial cord, another nerve is emerging over here, medial antebrachial cutaneous nerve. Medial antebrachial cutaneous nerve, it means it goes towards the arm and supply to the anteromedial portion of the skin of the arm over here. And you can see the terminal branches, the musculocutaneous nerve. The musculocutaneous nerve is arising from the lateral cord. And over here, from the lateral cord, one root goes downward, another goes are coming from the medial cord. This large nerve, which is forming by the lateral as well as the medial cord. One root is arising from the lateral cord, we say the lateral root. Another root is arising from the medial cord, we say the medial root. When this lateral and medial root are unite together, they forming the median nerve. Musculocutaneous, that is arising from the lateral cord. In such a way, from the posterior cord, there are two other terminal nerves are arising. One is the axillary nerve and another is the radial nerve. Now the root are very important. If you just, one person ask from you, what is the root value of the musculocutaneous, you can say just go over here. You see, that is the root value, C5 is involved over here. Then again connect over there, C7 is involved. When the C7 is involved, such a way the C6 is involved. One, if you ask that what is the root value of the musculocutaneous, then you can say C5, C6 and the C7 is the root value of the musculocutaneous nerve. One that asks that what is the root value of the median nerve, if you see that the lateral cord and the medial root, all the roots are involved from C5 to T1. It means the root value of the median nerve is C5 to T1. In such a way, the ulnar nerve, that is the root value involves C8 and the T1. In such a way, you can also remember the roots value, and the remembering of the roots value is very important. This is the another view which is showing the different branches over there, major terminal branches from the lateral cord, the musculocutaneous, median and ulnar, radial and axillary over here. Cutaneous innervation of the upper limb, as you just see that over there, medial cutaneous nerve of the arm is supplying towards the medial side of the arm of the skin over there, and superior lateral cutaneous nerve of the arm over there, C5, C6, C5, C6. In all the name of these nerves, you can observe that is the root value which is mentioned over here, and that root value is also important because when the injury is occur into the brachial plexus level, we can just distinguish on the basis of these root value. This is the another view of the skin which is supplying by the different nerves. Now the important nerve and the area of the supply, median nerve. Median nerve formed by the medial and lateral cord, as we have learned, supply all the flexure of the forearm except the flexor carpi ulnaris and medial half of the flexor digitorum profundus. Intrinsic muscles in the lateral palm, including the thenar eminence. Injury to the median nerve, when the injury is occurred to the median nerve, that is known as the ab end or Simon end. Obviously, inability to abduct the thumb. When we say that all the fingers and the thumb and the forearm, which is supplying by the flexor of the forearm, except the two muscles, that is the carpi ulnaris and medial of the flexor digitorum profundus, when the function of these muscles become lost, obviously the function of the function of the muscle lost by the damage of the nerve, and the nerve is supplying to these muscles are the median nerve, then the action of this muscle will be lost. That is the wrist flexion, finger flexion, and thumb opposition. Ulnar nerve supplies the medial half of the flexor digitorum profundus and flexor carpi ulnaris. Supply most of the intrinsic muscles of the hand, including the hypothenar muscles and the skins on the medial side of the hand, and injury to the ulnar nerve. Motor response to the ulnar nerve stimulations over here, obviously it's showing over there, that is the ulnar deviation of the wrist, metacarpophalangeal flexion, you can see over there, and the thumb adductions which occur, and that injury of the ulnar nerve goes towards the claw hand. Musculocutaneous nerve supplies the biceps, coracobrachialis, and the brachialis. Musculocutaneous, as name indicate, it means the nerve which supply the muscle as well as of the skin. Axillary nerve supply the deltoid and teres minor muscle and the shoulder joint. A radial nerve supply the tricep, brachioradialis, most of the extensor of the forearm. Injury to this nerve or the radial nerve, that is the wrist drop over here. Now injuries of the brachial plexus. Brachial plexus injuries, most common injuries is the severe traction with arm abduction, for example after a motorcycle accident. Partial paralysis may also result from the shoulder dislocation. Direct injury to the brachial plexus can result from the stab or gunshot wound. In adults, mostly the sports most common associated sports which may occur the injury, that is the soccer or the football, baseball, basketball, volleyball, wrestling, and gymnastics. Nerve injuries can result from the blunt force, that is the trauma or poor posture of the chronic repetitive stress. Patient generally presents with the pain and the muscle weakness. Some patients may experience of the muscle atrophy. There is a rarely muscle atrophy may occur. Now it may result the anesthesia, loss of sensation, may result of the paralysis. Paralysis may be complete or partial, or the incomplete you can say. Then mechanism of the injury, how traction, first of all the traction occur on the neck, direct blow to the shoulder over here, and the neck laterally flags towards the unaffected shoulder, as for example gymnast falls on the beam. Direct trauma, direct blow to the supraclavicular fossa or the Erb's point. We are coming to that, what is the Erb's point. Cervical nerve compressions, over here you can see the cervical nerve compression occurs when the neck is flexed towards the lateral side mostly, and patient affected the shoulder, compressing a irritating nerve resulting in a point tenderness or involve the vertebrae or the affected nerve. Erb's paralysis, first of all, occurs as a result of damage to the upper trunk of the brachial plexus. Upper trunk, just remember, due to the accidental fall or birth injury, when the baby is born wrongly method, that the head is just pulled in a wrong angle, that it may cause the injury to the brachial plexus. Then the roots at this level may injured at the C5 and C6. Now obviously when the roots are injured, as I told you, the roots are very important. The roots of this C5 and C6, that the nerve which is involved are emerging from these two roots, that is suprascapular nerve to the brachial, subclavius, lateral pectoral nerve, axillary nerve, musculocutaneous nerve. That Erb's paralysis, first of all, it is described by the William H. Eyre in 1874, and it involves the upper root or describe the certain types of the delivery paralysis. It means the upper arm become paralyzed. How it become paralyzed? It paralyzed due to the wrong way of the delivery, and the head is pulled in a wrong way, and due to the wrong way pullness of the head, the nerve become damaged over here. are directly the roots of the nerve become damaged. Arm is what happened into the Erb's paralysis. That deformity is known as the Vater strip deformity. What happened into this one? Arm is placed in an abducted position. Over here you can see, and medially rotated. Forearm is pronated and the palm facing backward, present a classical Vater strip deformity. What happens into the Erb's paralysis? Loss of abduction of the arm due to the damage to the supraclavicular nerve, which supply the supraspinatus muscle, and axillary nerve, which supply the deltoid muscle. Arm is medially rotated due to the paralysis of which muscle? Lateral rotator muscle of the arm. What are the lateral rotator muscle? Teres minor, supplied by the axillary nerve, and infraspinatus muscle, which is supplied by the supraclavicular nerve. Loss of flexion at the elbow joint, and that loss of flexion at the elbow joint due to the paralysis of the bicep brachii muscles, and that bicep brachii muscle results from the damage of the musculocutaneous nerve. Forearm is pronated due to the unopposed action of the pronator teres muscle as a result of the paralysis of the biceps. This is the another view. Decreased hand size of the contraction, Vater strip deformity. That is the Vater strip deformity over there, and internally rotated and contracture of the shoulder with the lateral gliding left of the scapula, and the arm is undeveloped, and the elbow flexion of the contracture. As I told you, due to the nerve damage, there is a little bit hypertrophy is also occur into the muscles, as showing into this peak. Injury to the trunk. Injury to the trunk that occurs known as the Klumpke palsy, or the Klump's or Digerian palsy, because in 1885 the Augusta Klumpke first described the clinical picture resulting from the injury to the lower root or injury to the trunk over here. Injury to the lower root is obviously, when we say the lower root, it means the C8 and T1 results in the Klumpke's paralysis. The ulnar and medial nerve affected. Paralysis of all the intrinsic muscle of the hand. That is the showing the Klumpke's paralysis or palsy. Over here, excessive abduction of the arm, you can see the excessive abduction of the arm over there. Small muscle of the hand become loss. Medial aspect of the upper limb of the loss. Motor losses occur into the small muscle of the hand, and sensory losses occur on the medial aspect of the upper limb over here. Now this is the point, we can say, that is the Erb's point. Erb's point, in other words, the C5 and C6 root are involved, and from these roots the nerve which is emerging, all these nerves becomes damaged, and all these nerves when become damaged, they supplying the muscles of the upper arm as the musculocutaneous, muscles of the shoulder by the axillary nerve, muscles of the lower arm and the hand by the radial nerve, and the long thoracic nerve is going over there. Then the Erb's point, when become damaged, all the function of these muscles becomes damaged, and that is the C8 to T1, that is the Klumpke's point, location for the injury of the Klumpke's palsy, because the Klumpke's palsies occur at the lower level over here. Now the median nerve formed by the medial and lateral cord, we know very well, supply all the flexor of the forearm and ulnaris. Now in this figure we can just say the Simon or ab end over here, inability to abduct the thumb. Over here you can see that the motor response to the median nerve, when we give the stimulation to the motor response over there, then the wrist flexion, finger flexion and the thumb oppositions may occur. But when it becomes damaged, then the ab end or the Simon end is occur. It is not able to flex all these responses over here. Then another ulnar nerve injury, which causes the claw hand. What happens? Medial half of the flexor digitorum profundus and flexor carpi ulnaris. Over here, that most of the intrinsic muscle of the hand, apothenar eminence and ischion and anesthesia analgesia along the way. In this pic you can see over here, when we just give the motor response over here on the ulnar nerve stimulations over there, ulnar deviate of the wrist, metacarpophalangeal flexion and thumb abduction. adduction is over here. When they are, the ulnar nerve become damaged, all these functions become lost, and the claw line is occur over here. As the radial nerve injury that causes the wrist drop, as obviously it causes the wrist drop, it supply the tricep, brachioradialis, most of the extensor of the forearm over here. We can see over here wrist extension, metacarpophalangeal extension, thumb extensions over there, elbow extension, supination, they are intact. When the muscles become, function of the muscles become lost, it means the nerve is damaged, because the nerve is supplying these muscles over here. Cervical rib. This cervical rib is extra rib which may arise apart from the 7th cervical vertebrae. It's a congenital abnormality located above normal of the first rib. When it just above to the first rib, and it estimated occurs in 0.2%, 1 in 500 people, and 0.5% of the population, involve the inferior part of the plexus. Now what happened in the cervical rib, that it just compressed the nerve root, because over here you can see the roots or the passage of the nerve is just limited for the normal existence over here. When another thing which develop at the normal site or the normal road, what happens? The road become blocked over here. And when the road become blocked over there, the structure which is passing over there, they obviously become compressed, and the cervical rib which just become compressed, the nerve root, and the persons feel the numbness into the hand, especially into the hand. Initial stage, what is the treatment of the cervical rib? That is the immobilization. Immobilization applied by the cervical collar. Initial stage, the soft cervical collar is applied. When it does not cover by the soft cervical, the hard cervical collar is applied over there for the 3 to 6 months. If the symptoms persist for a long time, then the cervical rib can be removed surgically. Now there are some questions of repeat. We can say the nerve root takes part in the formation of the brachial plexus are, what are they? A, B, C, D, E. Which one? You can say that is the D. C5, C6, C7, C8 and T1 are involved in the formation of the brachial plexus. Then the number of the nerve which meets at the Erb's point. It means the nerve are emerging from the Erb's point. They are how many nerve over there? They are 6 in number. You can count over there. Then the posterior cord of the brachial plexus give out of the following branch: ulnar, median, musculocutaneous, axillary, medial, pectoral. Which one? That is the axillary nerve. Posterior cord of the brachial plexus give out the axillary nerve. Then pick out of the component of the brachial plexus responsible for the formation of the median nerve. Medial and posterior cord, lateral and posterior cord, upper and lower trunk, posterior cord and lower trunk, lateral and medial cord. Which one you can say? That is the lateral and medial cord. If a question comes that a 20-year-old boy was brought in emergency with a history of fall on right shoulder, complaining of severe pain in the right arm. On examination, it was noticed that the arm hanged by the side was adducted and medially rotated. Forearm was extended and pronated. Biceps and supinator jerk were lost. Identify the structure responsible for this condition.